Hello, this is Rick Wiggins from the University of Utah, and today we're going to talk about facial trauma. I have nothing significant to disclose. So we're going to look at the important anatomy that happens around the face, and we're going to look at how that anatomy affects how these fractures are formed around the facial buttresses that we talk about, the struts that are important around the facial bones. Now, there are a lot of different ways to get blunt trauma that we think about, and that's very different sometimes than penetrating trauma that we'll talk about with both high velocity and low velocity impacts. So we'll start off first talking about the important anatomy of the face that's involved with trauma. And when we think about all the facial bones that are around the face, there are actually these important struts, anatomic struts or buttresses, and both the vertical and the horizontal plane, which affect how the face actually fractures with blunt trauma. And these are very important. So we can think about the individual bones that make up the face itself, or we can think about all of these buttresses or struts, both in the vertical plane and in the horizontal plane, and how they affect fractures around the face itself. So we have both horizontal and vertical supports or struts or buttresses that are around the facial bones. There are horizontal beams with a superior orbital rim and upper transverse rim right here. And that is sometimes called the inferior orbital rim, or with it connecting to the zygomatic arch. And we have the lower transverse maxillary, and that's the alveolar process right here of the maxilla itself. So this is the superior orbital rim. That's the horizontal buttress above the orbits. We have an upper transverse maxillary support or buttress. So that's the floor of the orbits and the zygomatic arches. And then we have the lower transverse maxillary buttress here in green, or the alveolar process. And then we have vertical buttresses. So on the vertical side, we have a medial maxillary, we see here in red. That's kind of the frontal nasal maxillary strut or buttress. And then we have a lateral buttress here in blue. That is the fronto-zygomatico-maxillary buttress or support. So just zoomed in, here in red, we have the medial maxillary buttress. And then here in blue, we have the lateral maxillary buttress or support. Now we also have mandibular buttress. So here kind of in orange, we have a superior mandibular buttress. And then here in purple, we have the inferior mandibular buttress itself. So when we think about fractures that are around the face, specifically transfacial fractures, we want to detect all of the fractures. And this is where it's very important when we're windowing the study that we want to window it specifically so that air is different than fat, so we can see where there's air and where there's fat. When it is possible, we want to think about those buttresses or supports and try to classify the fractures into these different groups. We want to look for possible complications and then describe the degree of displacement of the fracture fragments. So those are our objectives when we're thinking about facial fractures and different anatomic locations. So we're going to start out first by talking about the transfacial fractures and what they look at around anatomy. And we have three that are commonly talked about: the transmaxillary fracture, the pyramidal fracture, and the craniofacial separation, 1, 2, and 3 here at that level. So this is the transmaxillary, that's the pyramidal number 2, and the craniofacial separation is the number 3 type of fracture. And those are all actually in common. If you think about a lateral view, the commonality between them is that they all involve the pterygoid plates back here with those transfacial fractures. So they're more commonly called the Lefort fractures. So the transmaxillary is the Lefort 1, that's number 1 down here. The pyramidal is Lefort 2 in red, and the craniofacial separation is the Lefort 3 that goes through the orbits at that location. So we'll look at each of these and what they look like on imaging and how we define them. So first we have the Lefort 1. This is the horizontal maxillary fracture plane. And here the maxilla separates from the hard palate and the maxillary ridge. So it's sometimes called the floating palate. and we have a good chance of injury to both the greater and lesser palatine nerves, these little canals that open up at the back of the hard palate. So here in green, we see where that transmaxillary fracture is and how it goes back to involve those pterygoid plates posteriorly. That's the Lefort type 1. So here's an actual case that correlates nicely with that graphic. We have a lateral view of a 3D reconstruction, and we see that horizontal plane fracture of a transmaxillary fracture, or a Lefort type 1, that's going back posteriorly. So here's an axial CT, and we see the fractures here on both sides of the maxillary sinuses laterally, just above that alveolar ridge. And again, on a lateral view of a 3D reconstruction, we can see that transmaxillary fracture there. So as we go back posteriorly, we see how we got both of the medial and lateral walls of the maxillary sinuses on these coronal CT images. So next is the pyramidal, or the Lefort type 2. So here we're including the nasofrontal junction, but also the floors of both orbits and the medial walls, as well as the zygomaticomaxillary sutures and the posterior maxilla. And again, they all involve the pterygoid plates, and the Lefort type 2 is often described as the most common. It's pretty rare to see these in isolation, but here in red, we see what's thought of as the pyramidal fracture, or Lefort type 2, here in the anterior and the lateral view on this 3D reconstruction surface rendering. So here's an actual case. So here's an anterior view on 3D reconstruction, and we can see that pyramidal shape of the Lefort type 2 fracture that goes through both of the orbital floors down into the maxilla to reach those pterygoid plates posteriorly. So on this axial CT, we see the medial and lateral pterygoid plates, how they're involved with these pyramidal fractures. In another case, on an anterior view of a 3D reconstruction, we get again an idea of the pyramidal shape of the Lefort type 2 that goes through both of the orbits. Here's another case with a sagittal CT and the axial bone algorithm CT. So we see how we're involving the bilateral lateral maxillary walls. We also have some nasal bone fractures, as well as the midline nasal septum. And you see how you have both the anterior and the posterior wall of the maxillary sinuses involved in this case, including those pterygoid plates, where we think about the greater and lesser palatine canal going down inferiorly. And we see high density in the maxillary sinus consistent with blood on this CT study. So in the axial view, as we go up higher, we can think about where the lateral and medial walls of the orbits are. And we see involvement here of both maxillary lateral walls, but the medial lateral walls of the orbit may be intact. The pyramidal portion may go through the medial walls of both orbits. So the third is the Lefort type 3, that's the craniofacial separation. So here we include the nasofrontal junction, the medial floor and lateral walls of the orbit, as well as the zygomatic arches. And again, all of those Lefort fractures involve the pterygoid plates. So here in the anterior and the lateral view, we see in this line where we think about the craniofacial separation, or the Lefort type 3, that goes through the orbits at that location. And here's a nice correlating case with a lateral view of surface reconstructions. And we see those fractures go through the nasal bones and through the medial walls of both orbits. That goes down inferiorly to involve those pterygoid plates inferiorly. So through both orbits and then down inferiorly, consistent with that craniofacial separation. So if we look at an axial CT, we're going to see involvement of the medial walls of the orbits. And again, we see how that may go down inferiorly to involve the pterygoids. So here's the medial and lateral pterygoid plates. We think about all those Lefort fractures involving those pterygoid plates. And in this case, we can see where that superior, the greater and lesser palatine canals that are going down inferiorly towards that junction of the heart and palate. As we go up superiorly, we see here the zygomatic arches involved, the anterior and lateral walls of the maxillary sinuses, and we see the lateral walls of the orbits on both sides. And again, we think about these Lefort fractures as very rarely occurring in isolation. Often there's more fractures involved with those fascial bones. So that's what we think about with transfacial fractures, those Lefort fractures that are created because of those horizontal and vertical buttresses or struts. So next we have nasal orbital ethmoid fractures. So if we think about all the little bones that are between the orbits, that's the nasal orbital ethmoid fractures that may occur at that location. So we can have complications going both intracranially and towards the orbit with these small bones that may involve the important critical structures of the orbit at that level. So we look for nasolacrimal sac or duct injury. We look at the medial canthal tendon. We think about that little tendon going to the orbit, possibly being involved, and the nasofrontal drainage, possibly being involved of the nasofrontal duct draining the frontal sinus. So here's an axial CT. So we see depression of those nasal bones or pushback posteriorly in the medial walls of both orbits. And you can see comminuted fractures involving the frontal bones and those naso-orbital ethmoid bones medially. So right at the glabella, the little piece of bone that is in between both the orbits below your forehead, we think about that with the naso-orbital ethmoid fractures. And another example going up more superiorly, we have all these bones that are involved around the nasal-orbital ethmoid. If these fractures do not extend down to involve those pterygoid bones, then we're not going to call that a Lefort type fracture because we know all the Lefort fractures involve the pterygoid plates. And again, another nice example, we want to window it so that we can see where there's abnormal air at this location to help us look at these fractures of those facial bones. So next is the zygomaticomaxillary fractures. We sometimes talk about these as the tripod or quadrupod fractures. So we think about where that zygomatic arch is and the bone going up towards the frontal bone or towards the maxillary bone. So zygomatical frontal, zygomatical maxillary, zygomatical temporal, and zygomatical sphenoid may all be involved in these tripods or quadrupod fractures. So here's an axial CT in a oblique lateral surface rendering view, and we see this piece of bone right here going up towards the frontal bone with a fracture over to the maxilla, and a fracture of the zygomatic arch. So that's a good appearance for a tripod fracture. On the axial, we see here involvement of the zygomatic arch and the anterior and the lateral wall of the maxillary sinus. So this little piece of bone may be loose. That's the tripod fracture or quadrupod fracture, depending on which bones are involved. Here's another case, two separate cases. So on this side, we have the zygomatic arch involved here, and we think about the anterior and posterior wall of the maxillary sinus. Here's another case where those bones are more depressed. So we got the anterior wall of the maxillary sinus, the posterior wall of the maxillary sinus, and the zygomatic arch. So that's a zygomaticomaxillary fracture or tripod fracture at that location. When we think about these in the coronal view, again, we think about the lateral wall of the orbit and the maxilla being involved here. Maybe the lateral wall of the maxilla we see is fractured at this location. And again, we look very closely to help us think about these fractures. Where is there air and where is there fat? So it's very important when we start looking at the extracranial head and neck and the facial bones to window the study something like 440 so that air is different than fat. And when we look at bone algorithms like this with a much wider window, we may have a window something like 4,400. Here we're going to again see where there's air that should not be at that location. And when we see air involving the orbit, we're going to be very suspicious of the floor of the orbit in that case for a possible fracture. Now we mentioned these different struts. We have vertical and horizontal struts or buttresses that make up the facial bones. And those can be involved especially with nasofrontal ethmoid fractures because of those struts and where the force is directed with blunt trauma. So here is a case where it looks like we have nasal bone fractures, and we're going to look very closely at the medial and lateral walls of the orbit to see if they're involved. And again, we're going to look very closely for where there's fat. So for the standard algorithm, we want to window level something like 440, so we can see where there's air and where there's fat, because that's very important for the facial bones and the extracranial head and neck. With nasomaxillary fractures, we again look very closely at those nasal bones to look for a little offset. If we see a air fluid level with high density within the maxillary sinus, we're going to be very suspicious of those bones. And we look at all of those walls to see if there may be a fracture of the anterior, the lateral, or the medial wall of those maxillary sinuses. Now, often these fractures just look very complex, and depending on the type of blunt trauma that the patient has, we may be looking at all these osseous fragments, and we're just discussing which osseous bones are involved. Does it go into the orbit? And again, how far those bones are displaced, as we see in this anterior view of a surface reconstruction of the bones of this maxilloalveolar fracture. So these fractures go down into the alveolar process and involves the maxilla and the floor of the orbit, and it looks like we have fractures extending into the orbit itself. So these 3D reconstructions are very helpful sometimes, especially for the surgeons who are thinking about reconstructing those facial bones for cosmesis. On an axial CT, again, the sphenotemporal, we think about the bones going back. So we may get the lateral wall of the orbit and the lateral wall over here, and where that greater wing and lesser wing of the sphenoid are in relationship to the lateral wall of the orbit. They may be involved in sphenotemporal bone fractures at this location. If the blunt trauma is directed more inferiorly, we may have mandibular fractures. So we often treat the mandible and we think about it as a ring. So we may have a fracture on one side and a TMJ dislocation on the contralateral side. But just like the pelvis, we think about the mandible as a ring. So if we see a fracture at one location, we're going to look very closely for a TMJ dislocation or a secondary fracture. Here's a case where we have multiple fractures there of the maxilla. Again, obviously, this is going to depend on the direction and type of blunt trauma that we get to the face itself. But we try to mention the offset of these different fragments. And if the surgeons are thinking about an ORIF plate, ORIF, open reduction and internal fixation, they may be helped by those surface renderings of the bones when they're thinking about reconstructing those osseous structures. So next we have orbital fractures. So when we think about the very complicated bones that make up the orbit itself, where we have the globe, we have the rectus muscles, we have all these nerves, importantly cranial nerves 3 through 6, all going through the supraorbital fissure. Cranial nerve 2 gets its own hole through the optic nerve canal. But the fat that is around all these structures is held under pressure by all of those bones that make up the complicated orbital osseous anatomy. So part of the frontal bone, the maxillary bone, the sphenoid bone, all of these bones contribute to the orbit itself. And it keeps all of those contents under pressure with the fat. And if we have a fracture with herniating fat, well, the patient may have diplopia postoperatively. So it's very important that we think about these complicated osseous structures that make up the walls of the orbit so that they can think about reconstructing those if they need to for surgical intervention in post-traumatic cases. So here's a nice graphic in a correlating case. If we think we have a fracture of the medial wall, the lamina propria, or the floor of the orbit, we look very closely for both herniating fat and muscle. So we think about these muscles, the rectus muscles that may be herniating through the fracture fragments into, for example, the maxillary sinus at this site. So we may have fat herniating or the muscle itself when we have orbit fractures. And we may have osseous fragments that penetrate the other surrounding bones, again, based on the type of complicated trauma that we may be dealing with in those cases. So if we do have a fracture fragment that is penetrating through other osseous structures, we want to be sure we mention that because that patient may be at risk for a CSF leak post-operatively if we think that may have gone intracranially. So we think about all of those walls and the pressure that keeps the orbit at that location. So if we have an orbital floor fracture, we may have herniating fat, and the muscle may be extending down into the fracture fragment itself. So we think about air fluid levels that we might see in the maxillary sinus to make us more suspicious of orbital floor fractures. But again, we look around to see everywhere that there's air. If we see intracranial air at any location, that's going to make us very suspicious of a roof of the orbit fracture. And we're going to look very closely at the bones around those areas to see what may be involved. So we may see simple fractures like we discussed, those tripod or quadrupod fractures, when we may involve the zygomatic arch as well as the lateral wall of the orbit and the lateral and anterior walls of the maxillary sinuses more inferiorly. We may have buckling here, which may impede the motion of those rectus muscles with orbital fractures. So that's where many planes, especially the coronal plane, is very helpful when we're thinking about possible medial wall of the orbit fractures with herniating fat at that location. And one of the things that we look for is a change in shape of the cross section of the rectus muscles. So we want those muscles to be more oblique. And if it's more rounded, we may think that that muscle may be clinically entrapped by that herniating fat because there are fascial slips that go around the muscle to the walls of the orbit. And if we do have a fracture with herniating fat, we can entrap one of those fascial slips without entrapping the entire muscle. And clinically, that patient may have an entrapped muscle with decreased motion of the orbit in that case. So here again, we look very closely for where there's air and where there's fat to help us differentiate them. So when we're thinking about orbital fractures, we want to pay attention to both the standard algorithm and the bone algorithm. So again, our standard algorithm is going to be a wider window, something like 440, compared to the much wider bone algorithm, something like 4,400, when we're thinking about subtle osseous changes. In this case, we had both medial wall and floor of the orbit fractures, and we see that herniating piece of bone with some herniating fat, and we see this muscle appears to be more rounded. So we might mention if this patient has decreased upward gaze, that may be a change of entrapment clinically. Here we see this medial rectus is very large. It looks very wide on this cut, much wider than the other side. So we're going to look very closely to think about muscle entrapment in these cases. Here's another coronal case where we have a lot of herniating fat that goes down inferiorly, and we can see that inferior rectus going down. But don't get caught up in satisfaction of search. Go ahead and look at the other walls, see if there isn't a medial wall of the orbit fracture, and look at the positions of those muscles compared to the other side, if the other side's not involved with a trauma, to think about possible clinical entrapment. Here's another case with a lot of herniating fat going down inferiorly into the maxilla. And again, that inferior rectus muscle may go down into the fracture fragments itself. Now, we're also checking very closely for globe trauma. Have we lost the round shape of the globe itself? We're going to look for fat that is around the globe that may be replaced. Here, there's some soft tissue posterior to the posterior edge of the globe. So we're going to think about a hematoma at that location. And we have a fascial slip that is around where the optic nerve hits the globe, sometimes called Tenon's capsule, where we can get a Tenon's capsule hematoma. That may be very exciting because we can get optic nerve ischemia in those cases. We also check the lenses. We can have lens dislocation in one of those cases. So we think about globe trauma, not only perforating the globe itself, but maybe dislocating the lens. Here's another case where the lens is pushed back posteriorly from a lens dislocation globe trauma. So to finish up, we have other types of trauma that we often discuss. Sometimes penetrating trauma is very important when we're thinking about possible vascular injuries with penetrating trauma, and pseudoaneurysm can be often overlooked on CT. We think about both low velocity and high velocity trauma. Usually low velocity is handguns and high velocity is rifles. That's important because of the energy created by the mass and the velocity. And trauma and damage can be determined by the energy created. So missiles can cause a lot of energy trauma by direct tissue damage, but also there's cavitation that may happen posterior to the bullet fragment itself because of that temporary cavity. And also the bullets may have a lot of courses, so they may zag around. So a bullet may go straight through, we may see an entry and an exit for a gunshot wound with a high velocity, but a low velocity gunshot wound may have an entry, but then we may just see pellets at different locations. So we think about where the entry and exit is. If we have something like shotgun, we may have shotgun pellets all over at a different location. And this is one of the cases where a CT as well as reconstructions can be very helpful when thinking about trying to reconstruct this penetrating trauma. So the reconstructions not only of the bones themselves with a curved reformat can help the surgeon think about reconstructing the mandible, but also those surface reconstructions can be very helpful when they're thinking about reconstructing the bones at that location. So those are all things that we think about with trauma to the facial bones. So we're going to think about the important anatomy in those vertical and horizontal buttresses. We're going to remember those transfacial or Lefort fractures. And we're going to remember, because of those struts, that there's nasal orbital, zygomatical maxillary, and orbital fractures that may be determined by the horizontal and the vertical buttresses that are around the face itself. So that is a whirlwind tour through facial trauma. So think about that anatomy and think about those buttresses that may affect how the bones are displaced, and think about the surrounding complications that you might see with these complicated cases. And I thank you very much for your attention.